morning, everybody. Before we get started, since I have the pulpit, I want to thank a number of my colleagues who reached out to me this weekend. For those of you that don't know, I grew up in Squirrel Hill in Pittsburgh, and sorry, wasn't sure what I was going to say, but I knew I had to say something. I grew up in Squirrel Hill, and those of you that know me know that Pittsburgh and that neighborhood really are who I am. A friend of mine said over Facebook this weekend, if you like anything about me, I guess she said, I have a lot of faults, and those are my own. But the good things, the things that you like about me, I got from my upbringing in that neighborhood. And obviously, I think everybody knows what happened and how that community was torn apart this weekend. But last night in Hilltop, the Denver and Colorado community came together, over 3,500 people of all races and religions and backgrounds came together in a show of unity and solidarity to support both the community in Pittsburgh and Squirrel Hill as well as the Jewish community around the country. So I want to again thank my colleagues that reached out this weekend. It was personally very meaningful and brought me and my family a lot of support. The only thing I would ask of you is be kind, be compassionate, be stronger than hate, and if you haven't done so, next week, make sure you vote. Vote with your heart. Vote with your compassion. Please, it matters. It matters to 11 families this weekend. It matters to a community, and it matters to me. So we are lucky enough to have Myron Yaster as a professor of anesthesiology here at University of Colorado and Children's Hospital. Myron was my first attending when I started my anesthesia residency at Johns Hopkins. And I'm not going to go into his CV because that would eat up the rest of the hour. Suffice it to say that Myron has had an indirect and direct impact on the field of pediatric anesthesiology that I'm not sure everybody in this room knows. Indirectly, Myron has played a major role in what we now know as the field of modern pediatric anesthesiology. Establishing the Society of for Pediatric Anesthesia, his research into pediatric and neonatal pain set up how we practice pediatric anesthesia today. Directly, he has mentored, I don't know, have you kept count? 140? 140 pediatric anesthesiologists around the country, many of whom have gone on to be leaders in the field, both academically, administratively, and I count him as one of my primary mentors in my career. More importantly, I count him as a close friend. He's going to talk today on post-craniotomy pain management and as a model for clinical trial research, and I guarantee you'll learn something today.
Good morning. Today's lecture is not going to be about pediatrics, or very little. It's going to be about the management of post-craniotomy pain, and to be perfectly honest, although that's the topic, there's a subtopic, and that is, how do you turn lemons into lemonade? Or better said, if you face a clinical problem, how can you solve it? So I've got a couple of disclosures. I have been funded in the past by 2 pharma companies, and some of this may come up, and if it does, I will tell you which ones. I think I will be talking about oxycodone, so that's important to know. And it's also important to know that even though I will be talking about these meds, they're often unlabeled for use in children, and you'll see, and I will mention that as well when I get to that part of the lecture. Okay, so at the end of this lecture, there's a couple of things that you should be able to come away with. You're going to come away with some knowledge about, does pain exist following craniotomy surgery? You're going to find out if it can be safely treated. We're going to learn something about Six Sigma, which is an industrial process of a statistical industrial process that is used to produce perfect products, and how we can use that in medicine. And I'm going to finish with some brand new information that has just recently been analyzed and submitted about what are the consequences, if any, if you don't treat pain well in this patient population. So how did this all start? In 2005, I got called to the principal's office. The president of the Johns Hopkins University, his secretary called me and said, drop whatever you're doing. Mr. Peterson needs to see you right now. And that's never a good thing. And when I arrived, I found out that there was a patient who was 15 years old who came to Johns Hopkins from some distance because of the fame of the surgeon, Ben Carson. He really was a really good surgeon before something happened to him. I'm not exactly sure what, but he was a great surgeon, and he attracted patients from all over the country and world. And he assured the family that not only was the surgery going to be successful and that his hands were the hands of God, but that we had a terrific pain service and that child would be comfortable after surgery. But what happened is that the child was writhing in pain and received no pain management. So I agreed with Mr. Peterson that this was intolerable, but I didn't know who the patient was, which was a great relief to me. And I wanted to find out what happened. And it turns out that the patient, although 15 years old, our PICU was full, and the patient was transferred to the adult neurosurgical intensive care unit for overnight stay. And in the NCCU, the adult unit, patients never receive analgesics, and in the pediatric ICU, they all received patient-controlled analgesia. So why was there this difference? Well, as you know, for moderate to severe pain, the most commonly used analgesics are opioids. And in neurosurgery, there's a 100-year tradition going back to Cushing that opioids are too dangerous to be used in this patient population. It would mask signs of neurologic injury. It can depress minute ventilation. It could cause cerebral edema. And there's a presumed lack of need. The brain itself has no pain fibers. So you can operate on the brain without any anesthesia. The problem is to get to the brain, you do have to go through skin, muscle, bone, and dura, which do have pain. But the consensus opinion among neurosurgeons was you should be happy you're alive following the surgery. There is no pain following the surgery, or minimal pain, and it does not need to be treated. And even if it did, you couldn't do it safely. So the question was, is pain a problem after the surgery? Even if it is a problem, can we treat it safely? And if we treat it, how should we treat it? And can Six Sigma, an industrial process of management, be used to treat it? And one of the key elements of this was to look at this data prospectively. A common error, I believe, in looking at a clinical problem is to open up chart reviews. Chart reviews are almost useless because the way the data is collected, it's very hard to really make sense of it. And if you want to really make an impression and fix a problem, you have to prospectively gather data to see if what is actually going on currently. So we're going to start this Six Sigma part of this lecture with a simple mind experiment. I'm going to give everybody in this room $40,000 to buy a car. It's Colorado. It's going to be an all-wheel drive car, I'm sure, but that's the goal. You're going to get $40,000, and here are your choices. So by a show of hands, who is going to buy a Chrysler? So for those of you in the front who can't look back, there was 0 hands raised. Who among you is going to buy a Buick? For those of you in the front, there's not a single person who raised their hand. When I was a kid growing up, Buicks were the doctor's car. If you were a doctor, that's what you drove. And today, in 2018, not a single person in this room is going to drive a Buick or a Chrysler. How about a Subaru? It's the state car of Colorado. More than half of the audience raised their hands. How about a Toyota? The other half. Okay. So, what happened? How is it that the American car industry, basically you who are educated, consumer, will not buy, but you will buy a Toyota or a Subaru? What happened? So Six Sigma is what happened. Six Sigma is actually is an American design issue that analyzes the process of how you manufacture things. And the goal is to get to the point where there are very close to 0 defects. What does Sigma mean? It just means a standard deviation. So when you're talking about Six Sigma, what you're really talking about is 6 standard deviations away from the mean. So 6 standard deviations from the mean. Whereas in medicine, most of the time, we're happy with something that's 2 standard deviations from the mean. And that's also, I should tell you, one of the problems that happened to GM. They were happy with 4 standard deviations from the mean. It's very difficult to get to 6 standard deviations from the mean. The whole central tenet of Six Sigma is you analyze every aspect of a process, and you find out where the defects are and eliminate them, which is why when you have a cell phone, it would be extraordinarily unusual for that cell phone to not work. They work beyond Six Sigma. They're almost at 7 Sigma. But Six Sigma is the gold standard. You're getting down to what turns out to be 3 defects per million. 3 defects per million. Whereas GM and Ford and Chrysler were happy with 5 or even 4 defects, Sigma, which is 230 to almost 6,000 defects per million. It takes a lot of money, it takes a lot of effort to go from 3, 4, 5 Sigma to 6 Sigma. But the failure to get to 6 Sigma means that even though it's expensive to do, if you don't do it, you lose your business, which is why almost all of American industry, almost all of international industry now works to achieve 6 Sigma. So again, it just means 6 standard deviations from the mean, 3 defects, 3.4 defects per million. So where do we fall into this category in terms of medicine? Does anybody think that we're working at 6 Sigma in medicine? Why is that? Not a single hand was raised. I'll show you how bad it really is. Now, I should tell you that anesthesiology is the role model for the rest of medicine because we exist at about 5 Sigma, and we're actually coming close to 6 Sigma. But the rest of our colleagues are really not doing a good job. I'll give you like a simple example of this. Many of you have had colds or have children who have colds. And you go to the doctor, and that doctor prescribes an antibiotic. That's actually a 1 Sigma error because colds are viral. The antibiotics are useless. That's 700,000 mistakes per million. And we just accept it. In anesthesia, as I told you, we're close to 5, but most of medicine works at really unbelievably high failure rates and error rates. And we know that although the system of medicine that we have here, the things we can do technologically are outstanding, we are often in positions where what we can deliver fails because the process is broken. So getting back to craniotomy, the first thing is if you're going to do this as a study, you have to define the problem. Simple definition, is there pain after surgery? And then you have to measure it prospectively. You can't do this retrospectively. You then analyze your data, and you find out where there can be room for improvement. You put the improvement step in, and then you do the whole process again, continuously improving what you're doing to get to that 3 error per million rate. So the following studies were all funded by the Jacob and Hilda Blaustein Foundation, which is a pain foundation at the Johns Hopkins University, and by the Richard Tradesman Endowed Chair. The Department of Anesthesia had an endowed chair in Dr. Tradesman's memory, and that money from that chair funded a lot of this research. Okay, so we know that in the 1990s, pain became a big issue. The idea became pain should be the 5th vital sign. Every patient was supposed to be asked, do you have pain? And on a score of 0 to 10, if you're an adult, what is it right now? So, was there compliance with this mandate? That was the very first question. Were physicians actually and nurses assessing pain postoperatively? We wanted to see, was there pain postoperatively? We really did not know. And then the final question is, if patients had pain, how was it being treated? So we got IRB approval, and data was collected prospectively on the first day of surgery and the first 2 days after surgery. We did a convenience cohort study of 200, the first 200 patients we could do, and you could see it was sort of split, male-female. The weight was about what you'd expect for adults. I should tell you that at Hopkins I did adult as well as pediatric anesthesia, and as I'll joke about later on, I actually became a member of the Department of Neurosurgery because of this research. I'm not the person who'd ever want to cut someone's brain, but it became important for them that this become an important part of their practice. The age was about what you'd expect for brain tumors, and it was also split supratentorial and suboccipital, and occipital, I'm sorry. We used visual analog scale, verbal numeric scales, all the things that is pretty common in everyday pain practice. Here are our results. You can't see it, but the compliance of neurosurgeons was 0. We looked at 200 charts and could not find a single pain observation by a neurosurgeon. What was equally bad was the anesthesiologist. We say, well, that's not so bad. It was 50%. These were the people who got consent from the patients. So they knew we were going to be specifically looking for this, and they still didn't do it. The surprising thing was actually this yellow bar, the NCCU nurses, this yellow bar. And the reason it's surprising is nurses are really pretty good about doing stuff that they're supposed to do. If they're supposed to get a pain assessment, they usually do it. So why was it so low? In our analysis, it was because we found out that the nurses were frustrated. Why get a pain score if it wasn't going to be treated? So they just stopped doing it. What we found was, and we checked, we had our own nurses check pain scores as well as the nurses in the unit and on the floors to see if they were similar, and we found that the floor nurses and the study nurses had the same results. And what you see, which is really important, that 60% of patients had moderate to severe pain. So pain was in fact quite common. And when it was common, it was actually quite significant. We also found that where the surgery was made a big difference. That the more, if you were subtentorial, if it was occipital surgery, the pain postoperatively was much worse than if it was supratentorial. Not that the supratentorials didn't have significant pain too, but the suboccipitals had more pain than we expected. And that has important implications, because if you're going to put in a design, if you're going to fix this problem, put in something to fix it, you have to know that you have to have these two groups separated, because they're going to have very different pain scores, and pain needs. And that means that if we had done this retrospectively, it's very unlikely that we would have found this. That's, again, the power of prospective analysis of data. We found that patients got acetaminophen. Acetaminophen is actually the mother's milk of pain management. But what we found is that 20% of patients got too little, and 20% got toxic doses of acetaminophen. Now, how could that be? Well, there's a maximum of 4,000 milligrams per day, and some patients were getting 6,000 or 7,000, especially once they left the unit, because they'd get their 1,000 every 6 hours, plus they would get Tylox, which also had acetaminophen in it. So 40% of the doses of simple drug like acetaminophen were incorrect, which in 6 sigma is just astonishingly bad. That means that, that's like 400,000 per million or more. So it's 1 or 2 sigma. Fentanyl was given to many, many patients, but it was given in micro doses, 25 to 50 mics every 2 hours. Patients weighed about 80 to 100 kilos. They received a couple of doses a day, but it was basically, to be honest, just pissing in the wind. In almost doses that don't make any sense to be effective. So what did we learn from this prospective analysis? Pain is common. 60% of patients had pain scores greater than 5. Approximately 20% had severe pain scores greater than 7. Patients who had surgery in the occipital area had more pain than supratentorial patients. An almost 40% error rate in acetaminophen. Patients were treated with almost homeopathic doses of fentanyl. And what we ended up doing is we now defined and found targets to attack to fix this. The results of this were published in the Journal of Neurosurgery. The chairman of the Department of Neurosurgery was astonished by all of this. And as I told you earlier, because of this and all the other things, he insisted that I become a member of the Department of Neurosurgery so they could get credit for these publications in the Journal of Neurosurgery. What's also important to know in this is, I'm not going to go through all of my colleagues here, but I want to just highlight Alan Gottschalk. Alan was an associate professor, and this became his mission. And from this point on, every paper that was done, Alan, who had plus-minus interest in this topic, now took it on as his mission. And he became the leader of a lot of the papers that I will now present as we go forward. So we used 6 sigma. We defined it, we measured it, we analyzed it. Now we've got to do something else. So what we did is we decided to do a randomized controlled trial, which is the best way. It's painful to do, but it's the best way to finally get a result. And again, because we knew that there was a difference in supra and infratentorial pain management, pain assessment, we did actually 2 prospective studies, one for supratentorial, one for infratentorial surgeries. Now, again, I'm not going to go through all the names here, but Athir Murad is another person, because this person was a fellow, and this became his fellow project, and you'll see he took this through many projects to now as an associate professor. So what we said is we know that IV-PCA is used very commonly. It's used in patients of all ages. It allows patients to give mini doses. It's quite effective. We knew it's popular, but amongst most patients, but neurosurgeons just said no way. We knew that it could be used in patients of all ages. We persuaded them to let us do this prospective trial. English-speaking patients, intracranial surgery, sort of the usual suspects of who you would exclude. Endpoints were pain scores and hourly fentanyl doses, as well as sedation scores. So what did we do? We got IRB approval, always have to do that. Next thing we did is we produced a standardized operating room anesthetic and a standardized post-op analgesic regimen. Patients were divided into 2 groups. I'd like you to notice that every patient got acetaminophen. At Johns Hopkins, intravenous acetaminophen is rarely, if ever, allowed in the hospital. I know that that's sort of a surprise to most of you, The University of Colorado, I think, works at a margin of over 10%. The state of Maryland hospitals are not allowed to work are mandated to work at a margin of only 1.5%. That's profit after expenses. So what does that mean? It's very hard to justify the use of a drug that costs $80 a dose when you can give it the equivalent analgesia for 2 cents a dose. So in our hospital at Hopkins, intravenous PCA was basically not allowed except in the most extraordinary circumstances. It was not used as water as it is done here. So even adult patients got rectal Tylenol there, as well as oral Tylenol, but they never got IV Tylenol in this protocol. Now, if you notice, they were divided into 2 groups, PRN and PCA. Look at this PRN thing. It's significantly more fentanyl than what we discovered in our preliminary study. If you remember, in the preliminary study, they got 25 to 50 mics every 2 hours, and here they could get it every 20 minutes. So it's not a real control. Well, the IRB said, under no circumstances will we allow you to do a study of this sort where you don't give patients pain management. We went back and said, but that's the standard. And they said, we don't care. That's cruel. We're not going to allow it. So in this study, the control actually got significantly more opioid than they would have gotten if they had not been in the study. You know, this is just to show you that the patient populations were identical in the 2 groups. And now I'm going to go through the results real quick because I have a lot of stuff to still go through. Pain scores, significant differences between the group that got the PRN and the PCA. The PCA group, much better pain. Fentanyl use, significantly more fentanyl use in the PCA group. No effect on heart rate, no effect on blood pressure, no effect on sedation, no effect on Glasgow Coma Scale, no effect on respiratory rate, no effect on oxygen saturation, no effect on nausea, vomiting. What did we learn? We could treat pain. We could let patients have free access to fentanyl. They would self-control themselves, get much more fentanyl than they would have gotten if a nurse had to give it to them. But despite getting the fentanyl, despite being in less pain, no effect on sedation, no effect on oxygenation, no effect on any of the things that everybody was afraid of. These results were published in the Journal of Neurosurgery, and now you see Athir, who was a fellow, is the first author, and Dr. Gottschalk is now the last author. And I moved further down the choo-choo train. We did the same exact study with suboccipital patients who had tumors in the cerebellum and so on, and exactly the same results. The patients who got PCA, much lower pain scores, no effect on sedation, no effect on meiosis, no effect on anything other than better pain control. What about pediatric patients? So, I mean, I am a pediatrician, pediatric anesthesiologist after all, so what about them? So we couldn't do this PCA arm versus PRN arm in our practice because 100% of our patients got PCA in the Children's Hospital. So what we did instead was to take 3 different institutions, Boston Children's Hospital, Children's Hospital of Philadelphia, and Hopkins, and we told them, do whatever you want to do. We don't care. Just use your regular practice. We're going to do that prospective analysis of what goes on in your practice. We're going to collect pain scores. We're going to collect how much opioid was being used, how it was being administered, whether there were any complications. So at CHOP, at the Children's Hospital of Philadelphia, there's no IV PCA. It's not allowed in this patient population. What's important to know is at CHOP, they have a very unusual neurosurgical system. If you have neurosurgery as a child in that hospital, you get admitted to the PICU, and you stay in the PICU throughout your entire hospitalization. So if you had surgery on Monday and you leave the hospital on Saturday, you're in the PICU that entire time. And that means you have a one-on-one or a one-on-two nurse. At Hopkins, you get admitted to the PICU on the first day, and then you go to the floor, and 100% of those patients got IV PCA with a basal infusion, and the PCA could be triggered by anybody. It could be triggered by the patient, it could be triggered by the nurse, it could be triggered by the parent. And that is very different than the system that exists here, and that PCA, or parent nurse-controlled analgesia, can be used in children of all ages, down to even, the first or second month of life. Now, Boston Children's had no institutional policy, which made it great because it was completely at the whim of whoever the attending was that day. So what did we find? Well, we found, first of all, that pain was very well controlled in all three systems. The pain scores were actually below 3 in all three institutions. They were 3 to 4, nobody higher than 4. And what you could see, Hopkins is in blue, and on the first day, patients are getting about the same mean amount of drug, but starting from the first postoperative day, the Hopkins group, no matter what kind of surgery you were having, was getting more morphine equivalents. You can look at the bars, the mean bars, to get the sense of that. What we also found was when patients were transitioned to oral medicines, the Hopkins group also got much more than the other two, which were much more similar. But despite the fact that there was more opioid in the Hopkins group than in the Boston Children's and Children's Hospital Philadelphia group, the pain scores were the same. There were also no differences in their recorded oxygen saturations and respiratory rates, which were other things that we were monitoring for. To me, one of the fascinating parts of this study was we asked the parents a Goldilocks question. Did your child receive too much medicine, just the right amount of medicine, or not enough medicine? And the not enough is in the light blue. And what's amazing is that at Hopkins, where the parents had complete access to the PCA device, that was the only group that felt that their child did not get enough pain medicine. And all the other systems where the parents had no say in it at all, they thought that their child had just enough and never not enough medicine. The conclusions from this were that opioids were used in all three institutions. The pain scores were identical in 3 institutions. The amount of opioid administered amongst the 3 institutions varied dramatically, and one institution had the most liberal policy, had the most dissatisfaction among parents. I can't explain that last finding. But what we did because of this at Hopkins, as I thought I told you, the PCA always had a basal infusion as well as a bolus. Because of this study, we eliminated the basal infusion in this patient population. And that, again, is part of this Six Sigma process. You discover you don't really need something, as well as if you do need something, and you can eliminate it or add it. This was also published in the Journal of Pediatric Anesthesia. And based on this, they then came back to us and said, the journal came back and said, could you give us like an overall treatment algorithm that could be used by people who don't have the skill sets and the other things that you do, the institutional programs that could be used to model it. So that's what we did as another paper. Okay, so that's where we were until, I guess, 2 years ago, 2.5 years ago, which is about the time that I came here. We still had one major project that had finished just before I got here. Because this is not atypical, when people move from one institution to another, there can then be, sometimes projects just fall into like this vacuum that doesn't get finished. So I was constantly calling my colleagues to say, look guys, we got to finish this, let's finish analyzing this. And there was then some internecine warfare amongst the many groups, which happens in every hospital. And finally, I can tell you that as of about a week ago, the 2 final papers are now been submitted, and I'm going to give you a taste of what we found in that study. So, we know that headache is one of the most common presenting symptoms that people have coming in for brain tumor surgery. That's one of the things that brings people to the hospital, or for analysis and diagnosis. It's also fairly common after craniotomy surgery, and nobody really has ever studied what that incidence is. And we know that for many surgical procedures, depending on how you treat them perioperatively, you can develop post-operative, neuropathic symptoms that can affect the quality of life. So we know this is true in breast tumor surgery. We know this is true even in inguinal hernia. No one had ever looked at this in the craniotomy patient. And the final thing is, could we affect some of these issues post-operatively if we knew what the incidence was? So again, this goes back to the Six Sigma idea. You don't look retrospectively. You look prospectively to gather data to find out where there are weaknesses or faults in the system. So we did a randomized control study. We did only supratentorial patients. It was in clinicaltrials.gov. We didn't use the infratentorials because of a surgical issue. One of the surgeons who was very pro this study left the institution. Another surgeon who was in the institution was adamantly opposed to his patients being involved in the study. So we just had to give up on that patient group. But we had complete buy-in in the surgeries on the supratentorial region, so that was the group that we decided to study. And what we did is we divided them into IV-PCA and PRN, and then we had telephone follow-ups at 1, 2, 3, and 6 months later. Our outcome measures were pre- and post-operatively numeric pain scores, quality of life, validated quality of life scores, and a neuropathic pain questionnaire. I'm going to go through what those are because you all know the 0 to 10. I'm not sure how many of you know about quality of life scores and neuropathic pain questionnaires, so I'll give you a flavor of that as well. And during the post-operative period, again, they were measured for pain and sedation. So the quality of life scores. There are 5 dimensions: pain, mobility, self-care, performance of usual activities of daily living, and there's also a segment on anxiety and depression. And then each dimension has the Goldilocks thing, either 0, moderate, or extreme. So those are the elements that you can look at for quality of life. For neuropathic pain, we used a short form because a lot of the stuff didn't make sense to be used in this patient population, but there were things that we wanted to know really about their skull and head. So we looked for numbness, tingling pain, and increased pain from light touch. Specifically, were they in pain when they brushed their hair or comb their hair? And again, in this one, rather than that 0, 1, 2 score system, it's a 0 to 10 scoring system. A Likert scale, 0 to 7, would probably have made more sense, but we used the validated forms that were available to us. And what we found, and this is sort of hot off the presses, I have to just say it this way, this hasn't been published yet. It's been submitted for publication. So if you're a reviewer and you get this, you got to go like this, nah. But this is stuff that some of this has not even been presented in abstract form, but it has been submitted for publication to the Journal of Neurosurgery. So what we found is that pain, often with neuropathic properties, and reduction of quality of life is fairly common after the surgery. And, perhaps it shouldn't be surprising. These people had brain tumors, and it's not surprising that these would be issues that would affect them. Just the nature of the tumor could have some effect in this, and the nature of the surgery. We found, just as in the previous studies, that PCA provided superior analgesia and the patients received significantly more fentanyl, and they had lower pain scores in the post-op period. That had no effect on the development of neuropathic pain post-operatively, which is different than some of the other studies done in other kinds of pain. And the final thing we found was what you were like beforehand, the amount of anxiety and pain you had before you came into surgery had dramatic effects on how much pain you had post-operatively and even how much neuropathic pain you had post-operatively. So there are, again, many elements from within this that we can use to target future results. Ultimately, the question is always, is this safe? So the original studies that I showed you were powered for efficacy, and they weren't powered for safety. To do a safety trial would require hundreds of patients in each arm because the differences were so small in the things that we would be looking for: respiratory rate, CO2, needing to have an emergency reoperation. So we thought that rather than looking at safety in general, we would look at the thing that was the biggest issue, which is what are the effects of fentanyl on respiration. And in the original studies, the way we measured respiration and its effects were, to be honest, pretty primitive. So we decided to really look at this really carefully. We were going to look at end-tidal CO2, capnography. We were going to look at respiratory rate from the monitors, the impedance pneumography. We're going to look at oxygen saturation. We were going to even get blood gases at times. What we found actually was not what we expected, which is, again, why it's always important to do things prospectively. Because some of the things we found were actually not only not what we expected, I would say were, in fact, counterintuitive. So the most important thing we found was that end-tidal CO2 was a terrible monitor. And that's the monitor that the Foundation of Anesthesia Education and Research and the Anesthesia Patient Safety Foundation has been pushing for. We found that it was actually a terrible monitor. The reason it was a terrible monitor was that, first, patients constantly take the thing off their faces. We had the Capnostream monitor, which is, if any of you have ever seen it, has prongs that go in the nose, and it has like a proboscis that hangs over the mouth so that you can pick up mouth breathers as well as nose breathers. And patients just hate that. It's like they can't eat. It gets in their way. It really is something that makes them uncomfortable. So a monitor that you don't wear is basically a useless monitor. The second thing we found, and this was the thing that was really unbelievable, that CO2s actually went down. They didn't go up when there was respiratory depression. What? And the reason is you're taking very shallow breaths, or if you have obstruction, the CO2 falls. But if you then tell the patient, take a deep breath, it goes from like 27 to 60, you know? So it turns out that CO2 was just a bad monitor. It didn't work well. What was a good monitor, though, was it was a very effective way, if the patient wore it, of respiratory rate. And we found in this study that respiratory rate was probably the most significant factor if you wanted to look at respiratory depression with opioids. Now, how to get that, we'll get to in another moment. The next thing we found was that oxygen saturation, and this is not an unexpected finding, but is one that we confirmed other people's results, was also useless. So oxygen saturation, you have to be dead before the oxygen saturation falls. And the reason that happens is, as you start to breathe less well, you always get supplemental oxygen. And nasal oxygen, face mask oxygen, blow-by oxygen. And that means that the SAT will stay normal until you've been apneic for a while. So SAT was not a good monitor. So what do we do with that? Where do we go through from here? So we've discovered that we have patients who have pain. We've discovered that we can treat them with fentanyl pretty easily. We've discovered that we still need a better method of respiratory monitoring, but are there other things we could do? So we've gone through that analysis part, and now we're into the intervention part. So we went to this model of the pain pathway, the simple pain model, and this is really open to anybody in the audience, because now that I'm here, this project is sort of in stasis, I guess it would be called. We could do some of this work here if any of you were interested, either as fellows or faculty. I would be more than happy to help anybody who wants to do this. For example, would nerve blocks with long-acting encapsulated bupivacaine be effective at reducing postoperative pain? Maybe you wouldn't need as much fentanyl. And one of the really nice things is if you buy into this thinking, the PCA becomes one of the key endpoints of measurement. So one group gets a block, the other group doesn't get a block, and all patients have PCA. You could look to see when do they get, how many PCA doses the patient gets, or time to first dose. So the PCA not only now becomes a crucial method of pain management, it actually becomes your method of analysis and a target of intervention by how many boluses or when a patient needs it. And would encapsulated local anesthetics help? Would wound soakers that are so commonly used in the children's hospital, would that be helpful in reducing post-op pain, and would it affect long-term outcome? We just don't know. The other drug that I think is fascinating, that would be a fabulous drug to study in this population, is methadone. Methadone is a fantastic drug that is underutilized in the Children's Hospital. I don't know how much it's used at the university, but it is a fantastic drug, long-acting, very potent, has NMDA blockade as well as part of it, so tolerance doesn't develop. We might be able to eliminate the need for PCA if we did a study with methadone. Very easy to do project. The one area, if you look at that previous figure, that I don't think is going to be useful is the use of the gabapentinoids. And the reason for that is those drugs are sedating. And I'm not really sure if a single dose perioperatively is worth the effects of sedation that that drug family produces. Although it is something that somebody should look at some point in the future. Maybe these patients should be started on this a week before they come to surgery. Again, hasn't been done, very easy to do if one wanted to do it. I think that the most important thing that came out of the respiratory monitoring study was we need better respiratory monitors. And those things now exist. There's a whole new spectrum of respiratory monitors that could be used not only in this kind of study, but in the tonsillectomy patients, in the patients with OSA, where you're worried about them postoperatively. Are the effects of your drugs and analgesics going to affect their breathing? And there are 3 interesting new products that are out there. One is very old, transcutaneous CO2. It sort of fell by the wayside because it burned the skin. They've got new models now that the manufacturers say doesn't do that. I don't know if they work. I have no vested interest in this. I don't know if it's a good monitor. I don't know if it's a bad monitor, but it's something worth pursuing. There are whole new sets of monitors in which you can get respiratory rate, which I told you was the most important monitor to use in patients receiving this, that can be derived from a pulse oximeter. Again, I read the papers on it. I don't understand the math, but there are respiratory rate monitors that can be derived from a pulse ox. Nellcor, which is what we use in our hospital, has a model. I don't know if it's been validated in children. I don't know if it's been validated in adults, but it's out there. It would be a great project to do, simple project to do. And then chest wall motion. The ones that we have in our current monitors are pretty primitive. There's a whole new family of these chest wall monitors that with a single calibrated breath that you can do in the operating room will not only give you respiratory rate, it'll even give you tidal volume. So again, a fantastic monitor that could be used in these kinds of studies prospectively rather than retrospectively. You don't want to do these, put it on people and say, oh, this is the best thing in the world, because then you can never study it for real. You want to introduce this stuff and study it prospectively to find out if it works. So I've just given you a journey that started from lemons and has opened up whole new avenues of therapy based on the simple process of using Six Sigma to analyze a problem prospectively, put in place a fix, follow what happens with the results prospectively. And I think I've answered all of the questions that I started out with today. Does pain exist following craniotomy surgery? It absolutely does. Can it be safely treated? We know that it can be effectively treated. I think the paper that'll come out that was submitted will show that it can be safely treated. Can Six Sigma be used in medical research? It absolutely can. And are there consequences if pain is treated poorly after craniotomy? From our study in adults, it doesn't look like how you treat the pain post-operatively will affect the development of neuropathic pain down the road. But would something with therapy that was introduced, say, a week before surgery, or would anti-anxiety drugs started before surgery have an effect on this post-operatively? We don't know, but we know we have a signal from our studies that that might be something worth studying. And with that, I'll say thank you, and I'll take whatever questions you've got. Dr. Brooks? So the question was, why did we use fentanyl rather than a long-acting agent? because it was hard to get the adult neurosurgeons to want any fentanyl, any opioid to be given. And if you sort of remember, in the beginning I told you when we did that prospective study that patients got fentanyl, but very small doses of it. Well, when I presented that to neurosurgery, to the neurosurgical grand rounds, the chairman of the Department of Neurosurgery stood up and said, "This data cannot be true." And I said, "Well, why is that?" He said, "Well, none of my patients are allowed to get fentanyl. So I know my patients were in the study. How could you show that fentanyl was given to my patients?" And the chief resident in neurosurgery stood up and said, "Well, Dr. Brem, they call us. They don't call you in the middle of the night. And we give them fentanyl." And because fentanyl was already being used by the neurosurgical house staff to the non-knowledge of the attendings, we thought we should start with the low-hanging fruit, that was a drug that the neurosurgeons as a group understood could be used. I think that the neurosurgeons were also shocked that the IRB insisted that the control arm not be their standard of care. Larry?
You referred to Alan there and demonstrated how they kind of took this and ran it career around it. If you had to give 2 or 3 pieces of quick advice to either trainees or junior faculty about how you get started.
Sure.
What should a junior faculty member or a trainee who wants to develop a career in academics do right now so that Alan becomes a model?
So Larry's question was, well, I started with, I mentioned that that Alan Gottschalk and Athir Murad were sort of youngish attendings and fellows when this project started, and how could anybody in the audience do the same thing? So I would say there are a couple of key elements. One, you have to find a problem that makes a difference. That's the very first thing. And this was a problem that I think people sort of got onto right away, that when we showed that there really was pain, that was something worth doing. That's the first step. The second is the most important single element in being able to do these kinds of projects is to have a mentor who has done this and can guide the younger faculty and fellows onto a project. The third element is money. You need money from somebody to fund clinical research like this. This was not expensive compared to a lot of other studies, but it did cost, I would guess that each study cost between $10,000 and $20,000. And that's in terms of nursing time and getting the pharmacy to randomize drugs and stuff. And we got that money from small endowment and from an endowed chair. A desperate need, I would say. If I was the hospital, I'd say we need an endowed chair in pediatric anesthesia. We need an endowed chair in anesthesia for adult anesthesia, really so that the income from those endowed chairs can pay for research, this kind of research. And the fourth thing is success. And I would say this may be the most important element, more than any of the other things. Nothing breeds success like success. You know how there's when you hear like a mutual fund company is being advertised on television, they'll go, past performance is no indication of future success. Complete bullshit. The only thing that matters is past performance. If you're successful, you will become more successful with each passing step. If you fail and fall off the map, then you're not going to go on. So it's not only important to figure out the right mentor, to have the right topic, you've got to be successful. And I think the job of the mentor is to help narrow the focus down so that when the project is done, it is publishable at the end. And then you get the taste of it and you want more and more of it. I think we're out of time. So thank you all again for listening.